Hi guys, I am mostly recovered and just in time to create this video for you on myasthenia gravis, which is the next of the autoimmune diseases that we're going to cover. Hopefully you're realizing that as far as your immunology education goes, at this point, we're actually moving away from talking about basically simple immunologic processes or reactions and moving into kind of the dysfunctions of the immune response. So I spent a good chunk of your early curriculum basically telling you about the good guys in the immune response, that how they were saving us from pathogens. And that's true, but a bad immune response is still a bad immune response, and that's what actually leads to disease. And myasthenia gravis is another one of those autoimmune diseases that's actually mainly mediated by antibodies. But because we're talking about IgG antibodies, we're also going to talk a little bit about T cells as well. Okay, as far as myasthenia gravis goes, we have a couple of main points we want to keep in mind. First off, as I already mentioned, it's an autoimmune disease. And myasthenia gravis literally translates to grave muscle weakness, and that's exactly what it does. It causes weakness and fatigability in the muscles. So a patient might wake up feeling awesome, like they feel well rested and functional, but then by the end of the day, they start to have more significant troubles, and particularly with motions that we do repetitively throughout the day. So an example they use in the osmosis video is chopping vegetables. But another thing to keep in mind, something we do repetitively throughout the day, many of you are probably doing it now, is blinking. So what you might see is you might see drooping eyelids, you might see double vision, because this is a motion that requires some muscular intervention that is repetitive that we do throughout the day. So by the end of the day, even just keeping their eyelids open can be difficult. It has kind of an interesting pattern in the type of patients it affects, particularly women in their 20s to 30s or men in their 60s to 70s. And we don't really know why we see this bimodal presentation, but those are kind of the groups it affects the most. That doesn't mean that patients obviously outside of these guidelines can't be diagnosed, but those are the patients we see the most. And myasthenia gravis is a little strange. Most autoimmune diseases affect women more than men, but myasthenia gravis is actually one of the few where we actually see a fairly one-to-one ratio of women to men being affected by it. So just kind of an odd circumstance there. This is a type 2 hypersensitivity. So that automatically tells you a couple of things. One, it's antibody mediated, like we already talked about. And in this case, it's largely IgG antibodies. That also tells you it's tissue specific. So tissue specific, the last time we thought about this was when we were thinking about thyroid cases. And that made it really clear that it was all in the thyroid. Now, that gets a little confusing with myasthenia gravis, because remember, in this case, we're talking about muscles. You have muscles all over your body, so that can kind of make you think this is a systemic issue, but it's not, because the only target for these antibodies are the muscles. So it's very tissue specific. We just happen to have that tissue kind of throughout. There are a couple of haplotypes that are associated with an increased risk for developing myasthenia gravis, and in this case it's kind of interesting. We have two MHC class 2 haplotypes, HLA-DR3 and HLA-DR2, but we also have HLA-B8, which if you recall back to host defense and host response, these are MHC class 1 haplotypes here, and these two are MHC class 2. So that tells you that we have both CD4 and CD8 T cells potentially playing a role in the pathogenesis of this disease. All right, so I've already told you that myasthenia gravis is pretty much considered an antibody-mediated disease, and that's because those tend to be the things that cause disease. And that was actually originally found just in a study where they took the blood from a patient with myasthenia gravis and they separated it into two components. So they had the cells, which would include your white blood cells and your red blood cells over here, although they likely lysed the red blood cells, and then your serum over here. And your serum obviously contains your antibodies, all right? And then they took these antibodies and they transferred them into an animal, and lo and behold, the animal developed some muscle weakness. So that basically told us that the pathology or the symptoms of the disease that we were seeing had to be at least in part and significantly in part mediated by the antibodies. There are largely two different types of antibodies we're talking about with myasthenia gravis. The first is the anti-acetylcholine receptor, and the second is actually the anti-MuSK, which actually stands for muscle-specific tyrosine kinase. So I'll try to write that out in less than my normal chicken scratch so you guys can actually read it here on the screen. So these are the antibodies that we might expect to find in a patient with myasthenia gravis. Patients with anti-acetylcholine receptor tend to be more common, but there are about 10 to 20% of patients that do not have the anti-acetylcholine receptor antibodies that instead might have these MuSK antibodies. So first, let's think a little bit about what these antibodies might be doing. So with it being a type 2 hypersensitivity, we're concerned about two methods of potentially destroying the normal muscular contractility. Cytotoxic, which is the most common way that type 2 hypersensitivity is destroyed, and non-cytotoxic. And myasthenia gravis actually uses both. It's an equal opportunity offender. So let's talk about both of the ways. And first, let's just kind of review a little bit about what happens at the neuromuscular junction. Try not to mess this up too much so that Dr. Hepner doesn't yell at me. So at the neuromuscular junction, you have this neurotransmitter, acetylcholine. I'm assuming that's what these blue dots are in this crudely drawn cartoon here. Acetylcholine is basically released from the nerve cells and then is basically picked up by the muscle cell right here at the muscle membrane, right? So it's picked up by these acetylcholine receptors. Nice and handy, and that basically tells the muscle to contract. Well, just like we saw in Graves' disease, you get this antibody that binds right here, and when it binds, then the acetylcholine can't bind, and then you don't get muscle contraction. So that's a non-cytotoxic way that basically these antibodies just get in the way. They competitively inhibit the correct binding of acetylcholine to its receptor. The other way that they actually lead to poor muscle contraction is also non-cytotoxic, and that it actually leads to the degradation of the acetylcholine receptors. So antibodies tagging things is a good way to tell your cell, hey, we're done with this, get rid of it. So this tag on these two receptors tells the cell, oh, you know what, these acetylcholine receptors aren't any good. Why don't you break them in and then break them down? And that actually leads to a net decrease in the amount of acetylcholine receptors that are available for binding acetylcholine. So again, leading to reduced muscle contraction. The other way, which isn't shown here very clearly, is actually a way that we've talked about before, and this is actually the cytotoxic method. And this is really simple because you all obviously remember your immunology perfectly. But if I have an antibody here and it's bound to something, you know what binds really, really well to it? C1. And C1 is then going to set off a whole cascade of C4 to C2 to C3 to your C3 convertase. You guys know what I'm talking about by now. We're talking about complement. And anytime we're talking about complement, we're talking about things dying, right? And we're also talking about inflammation. So this cytotoxic method not only leads to complement induction, but also further inflammation, which will later also lead to death of the muscle cell. So in this way, we have both cytotoxic and non-cytotoxic. So I did all of this from the viewpoint of the anti-acetylcholine receptor antibodies. Like I said, there are also those anti-muscle specific tyrosine kinase antibodies. Those are also IgG subtype. And these tend to bind to the collagen tail subunit of the acetylcholinesterase, and that basically just blocks binding of acetylcholinesterase to the muscle-specific tyrosine kinase in the postsynaptic muscle membrane. And just like it did with anti-AChR, it likely leads to both cytotoxic and non-cytotoxic methods for inhibiting muscle contraction. And that's the entire immunology behind it. Now, there is one interesting phenomenon of some of these antibody-mediated autoimmune diseases that we haven't really covered yet, and that's the idea that A lot of these are due to IgG antibodies. Now, if you think all the way back to when we were learning about antibody classes, you know that different antibody classes have different functions. And aside from fixing complement really well, one of the things that IgG does is cross the placenta. And this is important because it's going to protect baby until the baby is old enough to kind of start making some of their own antibodies. In fact, when babies are born, they actually have a full complement of IgG antibodies from mom in their serum. And they rely on these serum IgG antibodies from mom to kind of keep them going. And eventually what we see is we see this decrease in mom's maternal antibodies as we see an increase in baby's own IgG antibodies. But in this case, the IgG antibodies aren't all protective, right? So if mom has Graves' disease, which we've talked about previously, or myasthenia gravis, the IgG can cross the placenta and then in the baby actually cause similar symptoms that we see in mom. And baby then would need to be treated to remove the antibodies from mom and therefore prevent the symptoms that we see. Now, most of the time, this isn't a very big deal. This is why it's called transient neonatal myasthenia gravis. Why? Because we're going to see mom's antibodies decrease over time, and baby is unlikely to make the same antibodies. So as mom's antibodies go away, baby probably doesn't make the same ones, and baby is fine. But we do see this phenomenon that is all due to the IgG just crossing the placenta. Okay, that's all I have on myasthenia gravis. If you have any further questions, feel free to email me and check out the rest of the videos for this module where we finish up the Clostridia genus.